I'm Michelle Kittleson, heart failure transplant cardiologist at Cedars-Sinai in Los Angeles, California. We're joined by Dr. Yuk Law. Dr. Law is director of the Cardiac Transplant and Heart Failure Service at Seattle Children's Hospital and professor in the Department of Pediatrics at the University of Washington School of Medicine. So speaking of echocardiography, are there specific observations that support a diagnosis of myocarditis over other causes of heart failure?
I wish we can nail the diagnosis of myocarditis in every single patient. And unfortunately, it's not that simple. Even if you go all the way to the top and are willing to do an invasive procedure like a biopsy or have the capability of having an MRI on every single patient, but you do have to start somewhere. So at the end of the day, clinical suspicion, your clinical acumen remains crucial. Okay, and what I would say is echo is very helpful when you get past the initial screening. For example, if a heart is huge, the Z-score for the LV end diastolic dimension, let's say above 4, 5, 6, and the walls are really thin, okay, I think that's less likely to be myocarditis. On the other hand, if you have an EF that's terrible, EF of 20, 30, even 40%, but the heart's not dilated, the LV walls are in general either normal in size or even a little thick, and maybe a touch of echo density suggesting maybe an edema, okay, then it is more likely that it's myocarditis. So if such a low EF and yet have not the heart remodeled, there is something acute going on. There is a differential for that. So I don't want people to think that you're done, that's myocarditis. But that would be a starting point to say, well, this is not dilated cardiomyopathy.
We take our history and physical as the top of the funnel. We narrow it down with our biomarkers, narrow it further with our echocardiogram. And then you mentioned endomyocardial biopsy, MRI. How do you decide which path to go in your patient?
This is why it's so important to get an expert panel from various backgrounds. And it depends on one's facility. We would love to do it, just get someone in the MRI scanner. I think when the heart is the echo phenotype that's less dilated and very dysfunctional, and you add an MRI to show some of the criteria that the adults have used, and we are following the same, I think you probably could be done. However, if the MRI is negative, or the MRI is not set up at your facility, then a biopsy is an option, okay? And the reason biopsies are still pretty popular among peds is because most of the myocarditis patients or heart failure patients are managed by transplant cardiologists. There are a lot of transplant centers that are not timid to do a biopsy, but they have to have their own internal quality assurance to say that our complication rate is so low, it's worth the risk-benefit ratio.